So I will be introducing our second speaker, Dr. Chua. He's a third-year preventive medicine resident undergoing specialist training in occupational medicine. He completed his Masters of Public Health and is trained in program evaluation. So he'll be sharing with us the evaluation findings and recommendations for SATA's migrant worker health education program on behalf of his team. So we welcome Dr. Chua.
Okay. Hi, good afternoon, everyone. So I'm Leng. Thank you, Hock Siang, for the introduction. So I'm a resident undergoing training in occupational medicine, and I just had the opportunity to learn about program evaluation earlier this year. So I'm not an expert in program evaluation, but just very happy to be here to share about what I know about program evaluation and our team's work with SATA. So I must emphasize that this was a piece of group work together with my team, and I'm presenting on their behalf. Okay, so this is an outline of my presentation. So I will first be sharing more about the health education program, an introduction to program evaluation, and followed by how we actually perform the evaluation and some of the findings, both the positive findings and some of the areas for improvement. And lastly, we'll be sharing about the recommendations which are proposed for the program. So I think, a lot of information has been already shared on the primary care plan, so I won't go into too much detail. Basically, it aims to provide workers with accessible and affordable healthcare, and SATA is one of the anchor operators. So this health education program is provided by SATA as part of the primary care plan, and it aims to help workers take ownership of their own health and reduce the frequency of clinic visits. And MPH students were involved in the evaluation of this health education program, as SATA was one of the partners for this module. So I'll just briefly introduce the workflow for the health education program. So basically, patients are selected ad hoc by doctors, and then health education will be delivered by healthcare associates, resident doctors, or nurses. And for information, healthcare associates are foreign doctors or nurses which are available to provide this health education services to the migrant workers in their native languages. And basically, this program is targeting workers with chronic conditions or workers with poor hygiene, as many of them have skin problems, skin infections. And the topics included touch on hygiene, prevention of chronic diseases, diet and exercise, and smoking cessation. So what is program evaluation, right? It's basically an assessment of the program or project or strategy in a systematic and objective manner. And in program evaluation, we analyze the level of achievement of expected and also unexpected results by examining factors such as the design, causality, processes, and contextual factors. And this evaluation is based on appropriate or suitable criteria, such as the relevance, effectiveness, efficiency, or sustainability and impact. And at the end of the evaluation, it should provide useful information and recommendations to guide decision-making for organizers and stakeholders. So just quickly covering why is there a need for evaluation, right? I already mentioned some of these previously. Basically, you want to understand what worked and to what extent the intended results were achieved by the program. And the second point is what did not work and whether there were any unintended results. For example, if the health education program resulted in a misunderstanding and then poor practices, that could be a possible unintended result. And third point would be to understand the implication of these results. And also that will help to promote accountability and learning. And lastly, program evaluation can help in planning, programming, budgeting, implementation, and reporting. So just a quick overview of the evaluation we performed for SATA. Basically, our team performed the process evaluation. So what this means traditionally is whether a program's activities have been implemented as intended and resulted in the intended outputs. But another broader way of thinking about it is whether a program will achieve its intended outcomes. That's after all what we're doing the evaluation for. And from the image, we can see that SATA runs PCP clinics at 3 sectors. And our evaluation was scoped down to that of the Woodlands Recreation Clinic, taking into account of our time and resource constraint, and also because Woodlands was one of the busier clinics when we had discussed with SATA. So this slide covers our key evaluation objectives in dark blue. Basically, we wanted to assess stakeholder satisfaction, and the questions we wanted to address were whether healthcare associates and migrant workers were satisfied with the delivery of health education, and whether migrant workers found the health education beneficial to them. Second objective was to assess the quality of the health education and understand whether healthcare associates were competent in the delivery of health education, and whether the materials used for the health education were accurate and comprehensive. And the third objective was the implementation of the health education program. So our team wanted to find out what was the proportion of eligible migrant workers who had undergone health education, and whether the health education program was implemented as planned. And the last objective was on moderating internal factors. Essentially, this just means whether there were any internal factors such as the comprehensiveness of the standard operating procedures or support by SATA in the organization. These are factors which can affect the rollout of the health education program. And so our team used a combination of methods to conduct the evaluation and answer these evaluation questions which I've mentioned previously. So the first method was through a survey of healthcare associates, doctors, and also migrant workers. So you can, our previous speakers have already shared many photos of the clinic. So basically, it can be quite a busy clinic with patients waiting for their turn. And the photo on the left shows a sample of the survey which we conducted. And these were just simple surveys which were crafted to better understand factors such as satisfaction with the health education program or perception of support from the staff. Yeah, and basically this is just a screenshot of on section A on example perception of support, and just a quick survey which our team went down to the clinic to conduct. And the second method we used was through observations. So our team went down to see how the health associates or doctors conducted the health education. And you can see on the photo on the right was some of the materials used during the health education on some of the lifestyle modifications, on let's say less fatty cuts of meat. And on the rightmost, that's a material from mybrother.sg, which was also used during the health education process. So we made use of a checklist, which we found after doing some literature search, and basically assess the components of the teaching, such as whether the use of the different types of teaching methods, whether the teaching was structured, and whether there was any opportunity for feedback and assessment. The next method we used was a desk review, basically of the health education materials which were used by SATA. And we also used an objective checklist for these, assessing aspects such as the content, the word choice, the organization of the information, and whether there were easy steps for the migrant workers to carry out, in other words, take action to improve the prevention of their chronic diseases. And the last method we used was the tracking log. So basically, because workers are selected ad hoc after a doctor review for the health education program, we wanted to assess whether the health education was conducted by a doctor or a healthcare associate, and also what topics needed to be covered. So that is under the checkbox on the left side. And then we compared that with another form on the right side. If the workers were referred for health education, we wanted to see whether they actually had the health education conducted and for the corresponding topics. So, yep. And with this data, we also compared with what information SATA had. So we had a rough estimate of patients with chronic diseases who underwent health education. Yep. So I'll just move on quickly to our findings. Basically, I've categorized them into our 4 objectives. So going through the positive points about what we found from our evaluation first. In terms of stakeholder satisfaction, staff were generally very satisfied with the health education program. SATA staff enjoyed delivering health education, and migrant workers were also satisfied and felt that there were opportunities to ask questions, and staff also listened carefully to their questions. In terms of quality of health education, this was also assessed to be satisfactory in terms of clarity of instruction, the organization and structure, and adaptation to learners' needs, and staff was also professional. Our desk review also showed that the materials were of good quality in terms of understandability, and also with small steps for migrant workers to take actions. In terms of implementation, there was a high utilization rate, and 71% of chronic patients received the health education. And lastly, based on survey with healthcare associates and doctors, there was a positive perception of support from SATA, with high ratings for logistical and training support. So I think these are very encouraging findings. Yep. So moving on to some of the areas for improvement. The first one is on communication. So despite an overall good satisfaction, we know that scoring on communication was low by healthcare associates and also doctors. And there was a perception by migrant workers that the health education wasn't clear when surveyed. And although most migrant workers said they understood the explanations from the health education session, they also expressed that there were language barriers identified. And in summary, the factors contributing to poor communication include a lack of time, a language barrier, poor literacy of migrant workers, and I think there were some healthcare associates who also highlighted that materials were not catered to minority races, such as Vietnamese and Thai. Regarding the quality of health education, some areas for improvement include engagement of learners, including whether learners were encouraged to participate and ask questions, and the teaching methods used was about whether the education was not just a lecture, but more whether there was a discussion or questioning, and also whether there was opportunity for feedback and assessment. In terms of implementation, although the overall utilization rate was high as mentioned earlier, we know that majority of the education sessions were actually conducted by medical doctors instead of healthcare associates, which was initially what was conveyed to us. And we also note there was one case of overlapping delivery of health education by both the doctors and the healthcare associate, so suggesting there was maybe there's a need to better rationalize the process and resources. So based on observations during our program evaluation, we also note that there was no fixed process for healthcare associates to pick up patients for health education. And there were differences in the way which health education was conducted for the patients. So we found that education sessions conducted by healthcare associates were more detailed. They used the materials for health education, and they focused on the prevention aspect and not only the presenting complaint. Well, because doctors had the patient load, the consultation was, the education session was shorter, mostly verbally, and focused on the presenting complaint instead of the prevention aspect as much. So other findings regarding implementation, we note that there wasn't a theory of change, and this will be covered later. Basically, it's a framework to guide the program. There was no available baseline data on migrant worker knowledge, on, for example, chronic diseases or hygiene, and there was also absence of a monitoring and evaluation plan. And for moderating internal factors, we also noted there was an absence of a standard operating procedure or detailed procedural steps for carrying out health education. So we provided some recommendations for the program based on domains of design, process, and future evaluation. So touching on design first, we suggested that SATA use a framework for the health education program and adopt a theory of change. And also this can be done by collaborating with NUS students for this. So what is the theory of change? Right? Some of us here may not be so familiar. It's basically a pathway of preconditions that must happen to achieve the desired outcome, and explains why each intervention component leads to a result. And why is it important is that it allows us to properly define and describe the problem and identify the changes we want and the steps needed for that change. And this needs to be evidence-based. It should be created with the stakeholders such as SATA, the staff, the management, because we all have blind spots. We may not be able to identify some of the actions that are required. So we worked together with SATA to come up with, to sort of conceptualize and piece together the theory of change which they had. So let me just show. Yeah, so basically this was the theory of change which we pieced together from our discussions with SATA. It starts off with the problem, and so we understand from SATA that they were trying to address this problem of a high patient load at the clinics. And the activities which came up with, including health education, and then also some mental health management strategies. And what these activities aim to do were to prevent chronic diseases, better manage chronic diseases, reduce prevalence of infections, and also improve mental well-being of the migrant workers, and eventually reduce patient load. But in our evaluation, we found out that actually chronic patients only accounted for 10% of the overall patient load. And these patients came in usually for routine follow-ups or exacerbations due to poor control of their chronic disease. So based on this finding, actually, the initial theory of change, in the initial theory of change, it would be hard to achieve the outcome of reducing patient load. And we redefined the problem. To that of a poor control of chronic health conditions amongst migrant workers, which would be more achievable with the current program. So just going back to the original theory of change, so what we did was we replaced or sort of amended the problem, which was that of a poor control of chronic health conditions, and the impact is the opposite of that. So meaning we want to achieve improved control of chronic health conditions amongst migrant workers. And then we worked backwards and found and sort of came up with the outcomes which we want to achieve, basically increasing the awareness of chronic disease management amongst migrant workers, improving their medical compliance, and also increase adherence to the health promoting behaviors. And from there, we came up with the activities which were required. Yep, correct. So, and we framed it based on the theory of planned behavior into the domains of attitudes, perceived norms, and self-efficacy. So actually, you can see from here that the health education program is only one part of the activities which we have listed. And under attitudes, other things include outreach programs, which have been mentioned earlier in the talk today, or video materials, informative leaflets. And other activities include encouraging support amongst peers, for example, social support groups, and to encourage self-efficacy, and so that individuals believe that they can actually achieve these changes. For example, distribution of tools such as pillboxes, which can enable migrant workers to actually improve their compliance to medications. So other than this, we actually need to also examine the assumptions, right? So because earlier in the talk this morning, some speakers mentioned about, developing this app, you may not actually achieve your outcome. So it's important to examine some of the assumptions and what else we need to add on to the theory of change. So essentially, a good theory of change is important to guide development of a logic model, which can then help us in identifying any inputs and resources required, the processes required, and any appropriate outcomes. Unfortunately, due to time constraints, I won't be going into the logic model. Yep. So the second recommendation on design that we recommended on was overcoming the language barrier. And this included creating educational videos in the native languages of foreign workers, which could possibly help with the lack of time and resources in the clinics, and also improve the variety of teaching methods available for the session, making it more interactive. And videos could also be used for easy sharing on messaging platforms and outreach to the workers. And another point was to include education materials in the minority languages as well. And again, this can address resource constraints. As mentioned earlier, it's not possible to have an interpreter who is competent in all languages. And as shown in the photos, the current education materials are already translated to Tamil, Bengali, Chinese, and so other languages that could be considered include Vietnamese and Thai. And actually, the resources from My Brother actually already includes like Thai, Burmese, and other languages. So, and the last point was to consider collaborating with NUS students also for this video creation. Yep. So moving on to process. Yep, so we recommended that SATA clearly define the roles and responsibilities for doctors and health associates. This ties in with our finding that most education was delivered by doctors instead of health associates, but actually the health associates delivered more detailed consultations and focused more on prevention, which is basically what we wanted from this health education program. And so it's important for the roles to be clearly defined and for doctors to focus on medical consultation, and perhaps healthcare associates can focus more on delivering the health education. And the next recommendation was to develop and establish an SOP or workflow for the program, including criteria for selection of patients, whether this is all chronic patients or specific groups of patients with poor control of chronic diseases, and tracking adherence to the workflow to understand whether the workflow is complied to when it's actually introduced. And as mentioned previously already, identifying a responsible person for health education, because if it's everyone's job, then it may not actually be done in the end. And lastly, to collect data for future evaluations to assess whether the intended outcomes have been achieved. So data collection need not actually be very extensive and time-consuming. So just show an example of a survey on knowledge, which could be done. So basically just to understand a simple pre- and post-program survey with basic questions to see whether the health education program actually increases the knowledge of the migrant workers. So the second recommendation for process was to improve the teaching and materials used for the health education program, tying in with our findings that there was room for improvement in terms of engagement, use of teaching methods, and feedback and assessment. So currently the program doesn't have a standardized training program for educators, and during our discussions with SATA, actually, there were questions on whether this was actually necessary, as healthcare associates were trained doctors and nurses. But actually, what we felt was that a standardized training program would be helpful, actually, to ensure consistent messaging, effective communication, as knowing something is different from teaching something. And also, a standardized sort of delivery will also facilitate evaluation of the program eventually. Okay. And our last point on future evaluation ties in with our finding that there was no baseline data collected and no monitoring and evaluation plan. So we recommended to incorporate surveys such as the knowledge surveys or surveys on attitudes, which had been shared previously, tracking logs, and use of objective checklists to assess observations of the health education program, which would be helpful in obtaining baseline data for future evaluations. So of course, a monitoring and evaluation plan should also be crafted, but this was beyond the scope of our evaluation. So my three main takeaways from our evaluation with SATA. The first point was the importance of program design. So even if the execution is perfect, we risk doing the wrong things rightly, and even if the design is wrong. And sometimes the program we have been asked to run by our bosses or management may just be part of a larger program which may be necessary to achieve intended outcomes. Yep. And my second takeaway is the importance of stakeholder engagement in program evaluation right from the start in our sort of problem identification, needs analysis, and also co-creation of the theory of change. It's very important to work together with the various stakeholders. And my last point is to celebrate successes. Basically, running such programs takes a lot of effort, especially with resource constraints, right? And it's important to recognize what we have been doing well so that we can continue to do those things well and improve and focus our efforts on areas for improvement to improve the program. Okay, so what next right for the care of migrant workers in line with the theme of the conference? So I think we are certainly moving in the right direction, and there remains numerous opportunities to improve health and well-being for migrant workers. So if you are interested in program evaluation and working with NUS, please reach out to Prof. Liao. His email is here, and then you can improve and evaluate your programs. If you have any further questions, you can also contact me at my email. Yeah, thank you.
All right, thank you, Dr. Chua. Please stay on the podium. We open for a quick Q&A from the floor if anyone has questions. Yes, please.
Hello, hi. I am one of the doctors at Alexandra Hospital. So we have been seeing some referrals from SATA Fullerton for migrant workers. Two questions. It's that the health education program, so for example, I see you have targeted a selected group of patients. You run through the health education program with them. is it a once-off session, or do you actually, after talking to them, telling them about their dietary lifestyle modifications, do you follow up on that same group of patients after that to follow up on their understanding whether they have adhered to the education strategies that you have told them?
Okay, so just to clarify, I'm not a SATA staff, but I was an NUS student
Yep.
working together with SATA on this program.
Yep.
So from my understanding of the program was that there, basically there wasn't any tracking of baseline data, so we wouldn't know if there was any follow-up or whether patients have had this education program multiple times. So in a sense, that is one of our recommendations to do something like that. Yeah.
Yeah.
Maybe I'll just add a quick word, because
Yeah.
I'm one of the doctors running the migrant worker clinics.
Yes, okay.
Dr. Chua is helping us from NUS
All
with
right.
the data. So I guess we have been, I'll just put in a quick word to say we have been established and our clinics are set and the migrant workers know where to go to. So our chronic patients, we do follow them up. We follow them regularly according to guidelines. So when they come back, we will definitely do the usual reassessments, look at the blood pressure, do their 6 monthly annual screens, and we will educate accordingly whenever they come back for follow-up.
Yeah. No, what I was asking is, for example, sometimes for a migrant worker, for example, they go through one session, and then after that, do you catch up with them like a few months later to see whether, are they still adhering to it? Are their understanding clear? Any further clarifications, or is it just a once-off session? That's what I was asking.
I would say we don't have the data, but on the ground, we do.
Okay.
I would just say we do, because we do follow up with them on their chronic conditions.
And the outcomes tracked for the outcomes from these strategies, outcomes tracked, do they include monitoring of, I think you've mentioned just now blood pressure control, but I would say screening for cholesterol, hyperlipidemia, diabetes? Are there objective measures for these from these healthcare strategies?
So as Dr. Chua has mentioned, I think we don't really have the data at this point of time. We will be sharing some annual health screen data later on from our next speaker.
Okay.
Yeah.
All right. Thank you.
Yeah. Any other questions for Dr. Chua, if any? If not, we'll move on to the next session. And just a quick token of appreciation for Dr. Chua.